Good afternoon. So this will be a fun panel. We're going to talk about telehealth, but I want to set the stage first. Let's talk about where the industry is moving towards. Very interesting stat: 52% of the Fortune 500 companies are gone since 2000. So what happened to them? They've been bankrupt, acquired, merged. But what's really been happening is the digital world, and they have been disrupted. So I want to ask you guys a quick question before we jump into this panel. Name a technology company in the last 10 years that has really revamped, or name a company in the last 10 years that has really revamped the industry or the stock market. Just shout it out. What comes top of mind? Apple, Google, Uber, Facebook, Amazon. So what you have listed is all these technology companies, but you know who has really disrupted the industry? Are you ready? Domino's Pizza. Okay? They killed the stock market, they really disrupted, and they changed their entire business model. So think about this. What did they do that's different? They became a digital company. Because now, what can you do with Domino's Pizza? Order your pizza on a mobile app, track the pizza. It may not be accurate, but you could track this pizza when it's being made. 7 minutes, it'll be delivered to your house. But the CEO for Domino's transformed the entire company to become a digital enterprise. So that's what all of us have to think about in our organizations. And today, as we jump into the panel on telehealth, the virtual care, it's really about creating that digital experience now. So we have 4 esteemed panelists that's here, that's gonna share their stories. So quick intro, Michael, I'll start with you.
Sure. Good afternoon, everyone. My name's Mike Pfeffer. I am the Chief Information Officer at UCLA Health.
William?
Hello, I'm William G. I'm a family practice doctor. I currently work at Loma University Health in the Inland Empire, and I support Loma Linda's telehealth with video visits, and I also support another initiative in the Inland Empire for their Medi-Cal managed care population in rolling out an e-consult platform in telehealth.
Hi, and thank you for having us here. Looking forward to a great discussion. I am Agha. I'm the Chief Medical Officer and EVP for West Health. We're based out of San Diego. We're a nonprofit organization dedicated to successful aging and healthcare cost. Over the last three to 5 years, we have developed this focus. And as we think about telehealth, there's tremendous opportunities in addressing both of those needs.
Good afternoon, everyone. My name is Omid Toloui. I lead digital health for CareMore. CareMore is an integrated health plan and care delivery system serving Medicare and Medicaid patients throughout the United States.
All right, great stuff. So I'll start with you, Omid. Tell me about your virtual care program and the telehealth program at CareMore. You know, what are you guys working on? What's the big differentiator? What's the problem you want to solve?
That's a lot. So, we essentially deliver care in 3 main ways. One is in our clinics. The other one is at home. And we see the third, area of care or the place of care as being virtual. And so we've taken a very deliberate and thoughtful approach to virtual care, trying to really preserve the intimacy of the clinical encounter, because we see that trust being a key component, the trust between a patient and a provider being a key component of virtual care. And if we degrade that trust, we think it's, virtual care and care essentially is not going to be as effective. And so we've built a virtual care center in Cerritos. It's a state-of-the-art facility that allows us to provide virtual care in a central location to patients either at home, at the bedside, or in our clinics. And we've been rolling out telepresence stands across all 60 clinics that we have throughout the United States. So we've essentially created a telepresence network that allows us, regardless of whether we're in the clinic or in the virtual care center, to see patients in clinic or at home.
Zia, what's going on at West Health?
So when we look at the work we are doing at West Health, we work both in the community and with the health system, and I think we've got really good expertise on the health system side here, so I'm going to focus on some interesting projects in the community. One that we're involved with is a community-based project with Meals on Wheels of America. Meals on Wheels has 5,000 outlets or franchises across the nation. They serve 2 million seniors, and they really are serving this population of vulnerable patients who have difficulty with preparing meals. But also, we know from research we have done that this is the population that accounts for 40 to 50% of preventable healthcare costs. And so the work with them is really around enabling their drivers with some really simple technology, but really reworking the workflows to be the monitors for these patients. These drivers are often the only people who go into these patients' homes. I should use the word clients because they're not yet patients. They go into the client's home and provide a meal, but they also socialize and talk to them. And there's the opportunity for them to collect some data and then take that data and send it to a care coordination center, and then you guys know what happens next. So that's an interesting project we have done, and as I look at the panel format today around scalability and dissemination, there's some work we're doing there to sort of create a learning collaborative at 10 sites and go to 50 next year.
Nice. Are they using smart plates? I'm kidding.
The food they're delivering is not very smart, and even the technology is very simple. It's just an app. They look for 6 changes in condition: medical, social, safety, those types of things. But we demonstrated in a small pilot with 2 sites, 382 alerts, which then led to follow-up activity and referrals. So it does work. Now the issue is, how do you scale it and how do you pay for it?
William, let's hear about your program.
So I guess I can honestly say I've been involved in telehealth for at least 20 years. I think the moment my friends and family know what my phone number is, they would call, and I've been engaging in telehealth. So just seeing all the different variations of telehealth has been really interesting. But any physicians in the room, you've probably been practicing telehealth for a long time. But what we're currently doing, I'll speak to 2 different kinds of programs. At the University Health System, what we've been rolling out is both e-visits or asynchronous communication visits for our self-insured employees, and then also rolling out video visits using our Epic platform. So that's been a program that's been growing, and we're going to be expanding hopefully to our other managed care populations. On the other side, we're also rolling out I've been involved in supporting an e-consult platform for our IHP health plan in the Inland Empire for the Medi-Cal population. There's a definite problem with specialist shortage. There's not enough appointments, not enough specialists for the million plus patients in the Inland Empire. And so by rolling out kind of a doctor-to-doctor e-consult support kind of system, in a way we're providing care for patients where we don't have to use up a lot of that access. So it's trying to improve utilization of our limited resources in the Empire.
Michael, what's going on at UCLA?
So this is a really great topic, and it's exciting because when you're kind of in my shoes in health IT at a place like UCLA, you get to see all these incredible innovations around telehealth. And we're doing a lot of the same things: video visits, e-consults, all of those things to really enhance the digital patient experience. And I think that's really where we're kind of looking at this from a strategic standpoint. It's really to say, if we, what is our strategy around the digital patient experience? As patient experience at UCLA is paramount, we always rank in the top 1 or 2 academic medical centers in terms of patient experience. So this is something we care very, very much about. So we've seen that these telehealth opportunities for our patients have really expanded the opportunities to interact with our providers. And as you know, Los Angeles is not the place you want to drive around or even park. And so while you continue to maintain your relationship with your providers, we want to provide that additional opportunities. So we're rolling out video visits across our entire enterprise, and really giving not only our patients an opportunity for a different way to interact, but our providers. And a lot about physician burnout and all of these things. Providers like to do these video visits, and so we're working to get them to do it at home as well, because that would be a nice thing for physician well-being. So it goes both ways. So we're really excited about that. I will tell you a story. You've probably read in the news about the measles outbreak at UCLA. There was a student on campus who contracted the measles, and so of course there's significant concern in the community about whether or not I have measles or not. So we actually were able to, instead of tell patients who are concerned to go to clinics, which if you had a case or a suspected case, you'd have to quarantine that clinic, we would route them to a video visit. So we would do this in real time through triage, through a video visit, so they could speak with a physician, and that physician can make a determination of further care. So this is just thinking about the opportunities around outbreaks and such. Telehealth really provides a great opportunity in that space.
Awesome. Let me ask the audience a question. How many of you guys, with a show of hands, prefer a video visit, telehealth visit versus in person? Raise your hand. The majority. I would say the majority. And 5 years ago in the industry, when you look at health systems, having a telehealth or virtual care program used to be a competitive advantage. Now it's not. Now it's a requirement. It's sort of, some places use it as a loss leader to create that stickiness, create that engagement, but you gotta have it. So question for you.
How about another question? Like, how many people have actually had a video visit with a doctor? Okay.
And one thing I've noticed is geographically, there's also a big disparity. So the coast, the East Coast and the West Coast, that is the preference. But where I lived and worked the last 3 years in Kansas City, they actually prefer an in-person visit. It's very different. But I want to start with you, Michael. How do you measure the success of the telehealth? Because now we know that we have this program in place, but you got to be able to measure this. How do you guys measure it at UCLA?
Well, I think there's a couple ways, depending on who you ask. So if you ask our CFO, are you getting paid for the telehealth visits? And we're very fortunate in California that we have the telehealth parity law. So for the most part, we do get reimbursed for that. So that's actually really important for our patients. Now there's the Medicare issue, which hopefully one day will be resolved. So that's kind of one way to make sure that you're at least financially viable, which I think is important for any kind of initiative that you do this day and age. And then uptake, so how many people are actually doing it, both on the provider side and on the patient side, and we survey our patients and they really love it. I think one of the interesting things about an integrated delivery network like UCLA Health, or the UCs together, because we're looking at ways to do telehealth across the UCs, is there's you have a relationship with the system. So if you're gonna have a video visit with a physician, they know everything about you because it's one medical record, it's one, you're not calling and they don't know anything about you. Whereas some of the the kind of doc in a box, as they say, where they don't really know anything about you and it's more an urgent care visit, may not be as sticky or as useful for a lot of people. So we like the idea that you can see your doctor in person, you can see specialists in person, but you can also see your doctor through a video visit or a partner or whatever, but they all know who you are. It's all integrated.
William?
I think initially what we look for success is really adoption, patient feedback in the surveys, and also on the physician side, how willing are they in successful in completing these video visits. What I'm hoping to see as we gain more and more visits and interactions is also patient outcomes. I think one of the big unknowns for a lot of physicians as they embark on this is the care the same, the outcomes the same, are patients going to suffer because it's not a face-to-face visit? And of course there's a lot of fears from those physicians, like if I don't lay hands on them, are they going to end up the same outcome? And so hopefully as we roll out more and more of these interactions and the visits, we can start looking at the data and say, okay, compared to the traditional visits, look, you don't need to worry, you're still providing excellent care and the patients are still being healthy, getting their needs taken care of, whether it's more the urgent care type visits versus chronic disease type visits. And I think what will be exciting is to start really looking at that information.
So our perspective at West Health is a little bit different since we work with seniors, and you mentioned that Medicare today does not pay for it in the fee-for-service system. But that's okay, because I really believe that telehealth is an enabler. It should not be something that you charge for separately. It should be part of your healthcare system. And as you move to value-based care, whether it's through MA plans or ACOs and other organizations, telehealth becomes critical. And we are seeing that happen with the shift towards more value-based care. And then in terms of outcomes, you stop counting telehealth visits as the outcome. You start looking at your net promoter score, your readmission rate, so the health outcomes then become prevalent, and those are what you're measuring for regular care. So it really becomes integrated as a program.
So you work with a lot of the seniors. Do you see a resistance to using technology, or do you see them accepting it? Because obviously they're FaceTiming with their grandkids, things like that. But do you see a big resistance there?
So we don't see resistance, and a lot of our work is not direct to consumer. I think when you design programs that are going to touch patients themselves, you have to do the education, you have to make the program easy to use. But in healthcare delivery, if you're using it for delivering access, delivering care, or monitoring through other mechanisms, like the example I used where there's a driver or a nurse who's actually using the technology, we see no problems with seniors using it. They have no concerns around privacy or security or other things. They just want to get care and get it in an affordable and accessible manner.
CareMore, how do you guys measure
Yeah.
success?
You know, I think as a Medicare Advantage plan, we're lucky that we're not encumbered by reimbursement. We're able to do what we think is best for the patient, and I think virtual care is one of those things. You know, I think what ultimately is a great measure of success, and this has been said somewhat indirectly earlier, is whether the patient sees that medical visit as just as good as seeing their patient, as seeing their provider in person. So if they see it as if they see themselves as sacrificing something or as losing something in the process, I think we're not doing a very good job of designing a program that is patient-centered. And so we've taken an approach of really trying to understand what are the little things that we can do to make that environment where we're providing virtual care, be it where the physician is sitting, where the patient is sitting, the technology that they're facing. How can we make it such that it's going to be as good and intimate as if they were seeing their provider in person? I think ultimately that has a pretty direct impact as well on outcomes.
So now that you have a mature program, if you had to think back the last few years, what are some of the lessons learned in terms of designing this telehealth program, and what would you do differently? So I'll start with Zia.
I think the programs that have been successful are the ones who have sort of addressed the engagement aspect early on. But more importantly, they haven't viewed it as a technical program. Yeah, they view it as clinical workflow and improving the workflow. And if you focus on studying the workflow to begin with, then you can make some improvements. So I think it's really important that those programs are going to bring something new. They understand what's happening to begin with, and then really address both the clinical workflow, but also from the patient's perspective, their workflow. So I think the technology piece has been solved. There's so many good companies and so many good gadgets out there. Where we stumble is we don't integrate with our workflows, and that becomes a sticking point.
So tech's easy, workflow's hard, people management is probably part of the process as well. William?
Well, in the two experiences I described, I've seen where if you don't have the right investment up front, can really make a big difference. So, for example, at the university itself, we've been talking about video visits and telehealth for many, many years, but it's just been very slow in development because we've just had so many projects around the campus, and there really wasn't a concerted effort. And then I compare and contrast to the rollout for the Medi-Cal population on e-consults, and where there's definitely a lot of resources invested up front to have the right number of team members to go out to the physicians, educate them, marketing materials for the patients. So I would say regardless of what your motivations are, you need to, if you're really serious about it, you have to have the right project management, the right physician champions, the right support invested up front. It cannot grow organically from a very small group of people. It just will take forever to get to where you're going.
So you mentioned lack of investment, lack of sort of priorities. Who leads it? Who's leading this effort? Is it a consortium, or do you have an actual leader in your organization?
So for the on campus for the for our self-insured plan, it started with a lot of fits and starts. So initially it'd just be maybe a couple people who just really think this is cool technology and thinks we need to do this. But gradually you start bringing in VPs and other department chairs and people like that. So you kind of have to have a critical mass of kind of campus leaders or organization leaders, and then you have to have the heavyweights, the people at the top, the C-suite, who really put their weight behind it. So it really wasn't until our the CEO of our health plan really got behind and said, okay, we're going to invest, we're going to actually pay you for this kind of stuff, that things really started taking off. In contrast, in the Inland Empire Health Plan, they started at the top with this initiative saying, look, we saw it work in LA, we want to make this work in Inland Empire, and they came up front, and then they had the resources, the money, and then they brought the team together to actually implement it. So it was just a different approach.
Yeah, so it sounds like every project, you must have the executive sponsorship. Can't always be led by the CIO. Throw that plug in there. All right, Michael, lessons learned from UCLA?
I mean, I think we're still learning. But I mean, just to echo what everybody said, I mean, this is not a technology problem, right? This is people and process and making sure it goes into the workflow. And when you have 40-something clinical departments or divisions, everyone is going to do it slightly different. So we have to be flexible, nimble, and then get really good leadership. So we have a medical director over telehealth that reports into the IT organization. They're a colorectal surgeon. They built an app partnered with us that reduces colorectal post-surgical readmissions for colorectal surgery by 50%. So she's incredibly engaged and is really driving more of the operations behind this, because the technical, it's done, it's in, and it's really getting people to adopt it. So we're still learning, and we'll probably still be learning for a long time.
What about CareMore?
Yeah, I think a lot of great insight has been shared. I think we know that the demand is there, right? There's patients, they want the convenience of virtual care. I think the issue is with supply and how you go about fulfilling the demand. Do you take time out of a clinician's regular schedule and make that virtual so they can see patients? But physician schedules, clinician schedules rarely run on time. When you're waiting for a virtual visit, you're sitting in front of your computer, your iPhone, your iPad. Time doesn't go as it's not as nice as sitting in a waiting room where maybe like there's some reading material, like a TV or something going on. So I think we had to play around a lot with, like, do we use existing resources? Do we dedicate resources? Do we dedicate a day of a resources time to being in the virtual care center to provide virtual care? How do we go about blocking parts of the schedule so it's just dedicated to virtual care so they can stay on time and not have those same issues? I think those are a lot of the challenges. Then working that into the EMR and the practice management system to make it all work is complex. And I think everyone's really touched on that. It's really the workflow that is the challenge as opposed to the technology.
So on the workflow, often the mistake we see made is that we'll go and do a needs assessment, maybe do a focus group, we'll talk to some KOLs, and then we stop. I'll give you 2 examples. A colleague of ours started a telehealth program for emergency care within nursing homes. He's an ER doctor. He went and lived in a nursing home for 3 weeks to understand the workflows, to meet the staff, and really get to understand what happens in the middle of the night when somebody falls. Why do they call 911? Yep. So you really have to embed yourself. For this Meals on Wheels project, we did drive-alongs with the drivers and went into the seniors' homes and noticed the interactions. We saw the situation. So if you really are going to address workflow, you really have to embed yourself in the work. You can't just do it by questionnaires and focus groups.
Yeah, that's a reality, right? We have to embed ourselves. We have to look at the operational components of it, because in academic medical centers, multi-specialties with different workflows and process, you try and throw in a telemedicine program, everyone does it differently. It is a pain to manage, and that's where the work really takes in place, in my experience, that challenge of even consolidating workflow from 40 specialties down to consistent 30, that's a big accomplishment, and slowly trying to get to as much of a standardized process as you can. So I want to take a pause and let the audience ask a question. Any questions for the panelists up here? So the question was, are you guys using your own physicians for the telehealth, correct?
Correct. So yes at UCLA.
Yes, for our university telehealth, it's all our own physicians, our faculty physicians. For the IEHP community, which is servicing 1.5 million patients, we're actually networking and building networks with community physicians and community specialists to network them together to provide e-consults.
In some of our projects, yes, it is the health systems physicians who provide care, but there are plenty of them where we use a vendor that has both the technology but also the services.
So we're very focused on providing, integrated, holistic care that's longitudinal. So we use all of our own clinicians.
So what happens if they're not your physicians? I think that's the key question, right? But if they're not employees, how do you manage them? What's the incentive? What's the incentive at West Health for the physicians, or do you just outsource it completely to one of the providers?
So there are incentives when there's shared risk, yeah. And some of these programs are sharing risk. So the provider or the vendor is only gonna get paid if there are better outcomes. So in that instance, somehow things align really well. Now, if it is a pure fee-for-service play, and you get paid for just seeing patients, then there are problems on both ends. There's overutilization on the consumer end, and sometimes there's overprescription, overutilization on the provider end, and you see that. So I think a lot of those issues get solved by incentivizing the right behavior.
So you touched on a good point about incentives, even sharing risk. What percentage of, like UCLA's contract is at risk? Because one of the things I talk about when I speak to various organizations, we all talk about value-based care, we all talk about population health management, but we're not really going at risk. Most organizations have less than 50% of contract at risk. So I'm curious, what's UCLA at?
It's pretty low. I mean, we have a UC health plan, which we're at risk. We have some ACOs and Medicare shared savings plans, but it's a small number compared to the fee-for-service for sure. I mean, we're a quaternary medical center, so we get a lot of people coming in for one procedure or one kind of surgery. And we also have over 180 clinics now all around Los Angeles, Orange County, and north. So we have a pretty large primary care base as well. So, but those are mostly still fee-for-service.
What about you, William? What are you seeing?
Well, at the university, like UCLA, we're an academic center, so the majority of our patients aren't at risk. But what I see happening, this telehealth definitely fits better when you're at risk or a managed population. Because when we talk about a fee-for-service model and you're trying to fit this on top of that, telehealth quickly becomes very transactional. The question of, okay, well, is it going to be a video visit where I might get paid more versus a e-visit, which is kind of like email back and forth, versus how do I differentiate between the telephone call, which is free, and is it really fair to the patient to say, oh, okay, well, really, this crosses this gray line where we're going to now charge you a copay for a video visit or for something. So it creates challenges when you're in that fee-for-service model. In many ways, I see it as it's very non-patient-centric. The ultimate patient-centric program, which is the most successful in my mind, is my friends and family calling me up because there's no financial motivation involved. I don't get paid for it, but and I have other motivations for taking care of my friends and family. So that's why I've been doing it for 20 years, right? So that is the other end of this spectrum, to be completely patient-centric, which is on demand whenever they want it and free. So go from that to fee-for-service. We need to find that happy medium, and I think when you have at-risk populations, you kind of maybe get towards that.
He'll be giving his phone number out at the end, so we can test this model of which is true.
I think the question is what's the alternative, right? If you don't have 24/7 access to a clinician, what's the alternative? You're going to end up in the emergency room. You're going to utilize more resources. It's going to lead to unnecessary hospitalizations, complications, et cetera, et cetera. So there really needs to be a push to make this accessible to all. Not a doctor. Look, I think it's a fallacy if we say that virtual care in 2019 can be a complete replacement for physicians. I certainly don't believe that. I think I speak for my organization too when I say we don't believe that as well. I do think it's a great way of supplementing care. I think there are certain types of care that are great for virtual care. Pharmacy, right? All of our clinics have access to a pharmacist. So when we have a patient come in that's complex on a bunch of different medications, and we want to do a pharmacy reconciliation, we can ensure that there's going to be a certified geriatric pharmacist there to help them with that. Behavioral health, another huge need in the United States. There's a shortage of providers, right? So we can centralize behavioral health providers that can see patients across a number of different clinics, not just one. And a lot of the patients we're dealing with are chronically ill. They have issues that come up. They need support. They need to know what the best next step is to take. And what I think telehealth allows us to do is to make sure that they're going to make the right best next step. So we can do an evaluation. We can understand what's going on with them. We can send a nurse into the home, a nurse practitioner into the home to provide them with treatment. If we want to direct them to one of our clinics, we can. Or if it's urgent, we can send them to an ER and urgent care, and we'll be there to see them. So, I agree. I think at a certain point, we're going to get to, I don't think we're there yet, but I think we're still a ways off, where you might actually be able to do that, right? You'll have all the equipment in the home, and things will be small, and sensors will allow you to do your differential and feel confident about the decisions that you're making, but I don't think we're there quite yet.
I think from a physician's perspective, we sort of shoot ourselves in the foot the moment we start thinking of it as a substitutive care model. Yep. We should be able to provide care to our patients using different tools and different methodologies, whether it's phone call, video, email, in person in the office, urgent care, ER, hospital, ICU. Yep. And it's up to us to decide at what point in this care continuum we are going to intervene and what tools to use. Often we have digital options. Yep. You either will, if somebody's calling me on a Friday night, you can either go to the ER or wait to see me on Monday. Yep. So we're just trying to create more options for both the patients, but also for the providers. And actually, providers like having those options so they can get better assessment and appropriate follow-up.
There's a lot to unpack in what you said, but what I would comment is to say, initially when companies are coming up with telehealth, and to me it was like glorified triage. There's only so much you can do. You ask a bunch of questions, and you basically, because of liability, I'm not going to commit to anything. I'm going to say, well, here's my 5 different diagnoses. You might really need to go see somebody to really differentiate that. But when I really think about it, I mean, in practicing both in urgent care or primary care clinics, you can arrive with a really good history and just some objective data that to narrow down the possibilities. And I think this is a great supplement to care, because it's part of that option. I've seen various programs where they kind of blend the idea that we do need to lay our hands on certain patients to differentiate. For better or for worse, I would say in practicing over the last 20 years, I've seen a shift. When I started, there was a lot more emphasis on physical exam. Again, unfortunately, our society, better or worse, we become very dependent on more and more technology, data, tests, CT scans, MRIs, X-rays, and so on and so forth. And you see each generation of physicians coming out, they're just more used to making decisions off of objective data now. And some of our students may not even realize how to really differentiate with the physical exam. So there's that kind of movement, and as the older physicians will be like, well, yeah, I'm a little more resistant because I'm just used to using my hands. And the newer generation of physicians are going to be more tailored towards telehealth, because they're less inclined to do that. They're more inclined to rely on the tests, especially as they become less and less expensive. Really cool initiatives out there where the doc is sitting somewhere else remotely, but they may have a nurse at a physical location to put the stethoscope on the chest and transmit that information. So in a way, you're getting some of that physical information, where if you have a well-trained staff member and you say, well, press the belly in the epigastric region, then I can trust that they're doing it the way I would do it, and I'm watching it while on a video. So there's different ways to kind of find that happy medium, and I think as we figure out this whole environment, you're going to see different ways of doing that so that the doctors get more comfortable. And the last thing I'll say is, even at Loma Linda, the different physicians, because we all have different ideas of what we can and can't do on a video visit or telehealth, we haven't figured it out yet. And I think the whole industry hasn't really figured it out yet of what is that standard, what is reasonable, what is not reasonable. So it'll be interesting to see how that develops over the next 5-10 years.
Yeah, it's one of the things that we're talking about is we need to incorporate this medical education during the training of virtual health. We're not incorporating that, so therefore it's not part of the routine, and we have to figure out how to incorporate that. You were going to say something, Michael?
Oh yeah, So it's a great question. I mean, so I'm a hospitalist physician, and I make my residents bedside round with me, which is going by the wayside. You now sit in front of a computer and card flip, and they look at me and they're like, "But you're the CIO. Why aren't we sitting in front of the computer and card flipping?" I'm like, "Because we learn so much just going into the room and seeing the patient." So I would agree. I mean, I don't think it's a replacement at all. I think it's just another way to increase our ability to connect with our patients. You know, kind of overall, we don't know what's going to work. Like, we need a lot of studies into this. And my guess is some areas are going to have, you know, data that's going to show it's a really good application. So I think, for example, post-surgical, it's actually probably going to work pretty well because you probably increase your follow-up rate and you probably get enough of what you need from the patient that you can do, you know, virtual. And other things that won't work. Maybe a new patient visit is not going to work for telehealth because you need to form that relationship in person, and then maybe the next visit, you know, you can have that video visit because you already have that relationship and you know the patient. We just don't know. And you know, one of the things, like, I get a lot of pitches for telehealth apps and apps and apps and apps, and there's millions of apps, but what's all missing in that is actual data, studies that show that yes, it does indeed reduce readmissions, or yes, it doesn't make things worse than coming in. So that's, I think, where we need to be in the next few years. We need to figure that out, and it's not going to be one size fits all. Just like AI, there's not going to be one sepsis algorithm that we're going to plug into all of our systems and it's going to work. It's going to be tailored to each place because of the unique patient populations that you see.
And I'll just drop two things. One, again, is really physician referral. So existing patients, if a physician says, yeah, this is great, I'm going to talk to you, you're more likely to get them to do it. And number two, yes, you do need a good marketing plan for new patients. And the key to that is not just a big marketing budget, but you also have to make sure the process is very simple. In our on-demand age of everything, it has to be absolutely the least amount of steps to get what you want right away. So whatever your marketing plan, you got to make sure signing up or getting it is going to be very simple.
So I think that's an important point to bring up, that the haves and the have-nots, yeah? So who has access to telehealth and who will not? Traditionally, when we talk about disparities in telehealth, we think the rural-urban divide, yeah? And telehealth programs have been very successful, and they were initially 10, 15 years ago, when I used to work for the VA, most of the programs were developed in rural sort of physician shortage areas, quote unquote. But we're seeing disparities in healthcare in urban cities, yeah, in LA and San Diego. How do we address that? That's a really important point. I don't think we have fixed that problem yet. I think those disparities that exist in healthcare access or social services, those are social and I would say political issues. It's not a tech issue per se that's going to solve it, but it's important to address that. I think you're spot on that this could make the divide worse.
Yeah.
I mean, I think the technology is right here, and you know, I think increasingly the Lifeline program, which is a subsidy program, we all pay for it actually as mobile phone users. Grants phones. You probably know more about this than I do, Zia. And I think there's some challenges with that. I think increasingly smartphones are becoming affordable, and so if you're on this program, you can get access to a smartphone, but it comes with a limited amount of minutes and data. So I think, you know, to your point, Zia, it's a policy issue as well. You know, what if we could give you that phone and we said, hey, if you want to contact your provider, we're not going to take those minutes away from you. We're not going to take that data away from you. I think that would go a long way to increasing access because it would open up a channel to allowing folks, many of which are working, to be able to access the healthcare system without necessarily being penalized because they're not going to be able to use that data to access other things.
I mean, I think both of these questions relate to patient engagement. And technology is going to, you know, is going to be key, but I don't think we've figured it out completely. So that's a big open space. I mean, one of the things that, this is a little bit of a tangent, but let's say we have an app or something that, or our health portal or whatever, that requires, post-surgical patients to have. And what if they don't have an iPhone and they have an Android and the app doesn't work on that? Or what if they don't have it and then the patients that leave the hospital with technology or have the technology, we know that their risk of readmission is 50% less than those that don't. And this goes back to policy and everything. I mean, how do we get those technologies in their hands? And it's not just going to be paid for by the hospital, right? I mean, that we have to think bigger than that, because even if the hospital gives everybody an iPad and then wants it back in 30 days, what happens then? And so how do we engage patients with technology? We need a lot of studies on that. And then two is, how do we, from a policy standpoint, get them the technology? And it's as simple as a phone. It's all you need these days.
All right, I think we're running out of time, but we had a great discussion. We all realized that the telehealth, virtual health program is not an end-all. It's not the perfect solution, but it's a stepping stone in terms of augmenting care. So round of applause for the panelists.